So we're going to talk just a little bit about Ortho Consult today, basically just some ortho basics. If you have questions, interrupt me anytime, and we'll try and get through it pretty quickly so we can look at some more of the surgical things of what I do on a regular basis, which I hopefully think you'll find more interesting than these. So disclosure, I have none for this talk. If you've ever seen an orthopedic talk, I've tried to include the usual gory extremity pictures and some surgical videos, which at least in the orthopedic world are almost always manageable. So hopefully you'll be able to follow along a little better than this guy. Let's see if this will play. So hopefully my English will be a little better than that for you. So we'll talk a little bit about orthopedic trauma and open fractures, urgent fractures, orthopedic emergencies, the things that we're looking for, for our pre-op, and which x-rays to order, and then hopefully we'll have some time to show you a little bit about what I do on a regular basis. So I'm sure you all know about the ABCs. Obviously that's first, despite a limb looking like that other picture. X-rays. We always like two views. I know sometimes they're just shooting spot views where they're just trying to figure out what's going on. But if there's an extremity in question, we usually would like a minimum of two views. For some other areas, we probably would like at least three views. If you're talking about a trauma, we generally like to see the joint above and below the fractures to make sure we're including the full zone of injury. Open fractures, there's a lot of different classifications out there. Your type 1s are typically your less than 1 centimeter wound, and they're often inside out. Those are some of the ones we see in the more elderly patients. The type 2s, those are between a centimeter and 10 centimeters, and those are a little more significant. And then with the type 3s, these are really bad injuries, either with really extensive trauma to the patient, or that type 3Cs, which are actually vascular injury requiring repair. And obviously, you want to get vascular involved as well as us if those were the issues. The main thing that's important with those grade 1, 2s, and 3s for non-orthopedic surgeons that are treating it. Sorry. Let's get rid of that. The main thing is to get the antibiotics to the patient as quickly as possible. And so that's why I included these slides with it. Obviously, local wound care, dress the wound, splint the limb, find out the tetanus status of the patient. And as I said, it's important to try and give IV antibiotics as quickly as possible, which pertains to the injury. And then once you get us involved, most of the time this will be an urgent surgical debridement. Obviously, if it's not open, that doesn't mean the soft tissues are not extremely important with bad fractures. There's something they call the Morale Lavale lesion, which is essentially an internal degloving, most often seen around the pelvis and the hip. And those are things that you want to get us involved pretty quickly with if you can, because those often require debridement and a drain. And looking at those x-rays pretty carefully, because those are pretty traumatic incidents. Dislocations, so obviously we want you to get us involved quickly if it's something you're not comfortable with reducing, to try and get that joint reduced, not only for the cartilage health, but obviously for the vascular health of the limb. The timing of reduction, just like I stated before, it's important to try and get these joints reduced as quickly as possible. There are some that are more urgent than others. Hip dislocations, for instance, if any of y'all are familiar with Bo Jackson, that was the end of his football career, is that he had a hip dislocation, and unfortunately he developed AVN. And I can't remember which of the orthopedic implant companies, but one of them is pretty happy because I believe he's on his third hip already, because he wore the first one out trying to play baseball on a total hip, which is not what we would recommend, especially the way he plays. So as I was saying, if it's a hip that's not reduced, we really want you to get it in pretty quickly. We try not to ever see these type of CT scans. Hopefully the person who's seeing them initially will be able to recognize that it is dislocated, and if they don't feel comfortable getting it back in, will get us involved pretty quickly. That way we can try and get it back in to try and preserve the hip, especially in younger patients where total hip, like Bo Jackson, would not be an ideal candidate. So with hip dislocations, some are very obvious and some are more subtle. You can see this one here in the top left. Let me see if I'm adept at this laser pointer. So you can see here, some people, would have just quickly brushed by that and said, oh, they just have a bad acetabular fracture. But upon further imaging, you'd be able to see that that hip is truly dislocated. And this is just, what was done with that. Indication for vascular studies. So with knee dislocations, it's very important to be thinking about the vascular status of the patient. I actually had a kid this past year. She was playing football directly in front of me, and it looked like a relatively innocuous knee injury that we see commonly on the field. And I went out to examine him, and he actually had a dislocated knee. Not a dislocated kneecap, but his femur was completely dislocated from where his tibia was. And so that was something that needed to be emergently taken to a hospital, not only to figure out the vascular status, but to make sure that there weren't any other significant injuries there. Unfortunately for him, he kind of got bounced from from this hospital to another one. And fortunately, I was following him after the game, and I caught up with him at Children's Hospital, where they were about to discharge him without doing any vascular studies or even doing ABIs on him. And that was because when he got to them, his knee looked fine because it was reduced, because I reduced it on the field. But otherwise he would have just been discharged home. But it was fortunate that he didn't have a vascular injury, just a multi-ligament injury, and he's still rehabbing. Specific problem fractures. So not all fractures are created equal. Femoral neck fractures I alluded to are very similar to the hip dislocations, where we're trying to preserve the vascularity to the femoral head, because if that's lost, then that patient needs hemiarthroplasty at minimum, and most often a total hip arthroplasty. So for patients under 60, a lot of times here at this hospital, we're used to seeing 60 and above patients with hip fractures, but 60 and below should be an orthopedic consult when that patient comes in, and then the surgeon of record can decide if that's a patient that they want to fix emergently, or whether they would treat them like an older patient. And 60 is not a hard, fast age, depending on who you ask, but I think that if you consulted somebody on anybody under 60, I think they'd be very pleased to get that consult early on, opposed to some of these hip fractures where we get the next morning, which is not a big deal. Displaced talus fracture, fracture dislocation, those are more obvious. Floating elbow or knee, so those are fractures above and below either the elbow or knee joint. Pediatric supracondylar humerus fractures, that's less commonly seen in this hospital for a similar reason to why my football player was sent from here in the first place. And scaphoid and carpal fracture dislocations, sometimes those could be a little more subtle, and if there's any question, those should get a CT scan, so that way they get prompt treatment, I should say. Let's see. So femoral neck fracture in a young patient. So this is one that's displaced. This would be a high risk for avascular necrosis. In a younger patient, that would be a very big deal, because we would like to try and preserve that femoral head if we can with doing an ORIF. And as I said before, in those patients over 60, doesn't need to be a prominent consult, because those are patients that are often going to get a hip hemiarthroplasty or a total hip, depending on their status.
What are the factors in the avascular necrosis occurring? What makes you suspicious that that particular patient?
Oh, this one here?
Might have avascular necrosis, you call it.
Sure. So this particular reason for avascular necrosis is traumatic. So you can see that the head is in varus compared to the shaft of the femur. So a displaced femoral neck fracture often disrupts the blood supply. It's between 30 and 40% that go on to avascular necrosis because they disrupt the circumflex artery there, which is the predominant blood supply to the head in most people. That one didn't come out very well. These are just examples of the ones, I'm just showing you x-rays of the ones we talked about before. You can see floating knee here with the femur and the tibia fractured. So hip fractures, I figured I'd spend a little extra time since this seems to be a hospital where we get a number of hip fractures. So the radiologists are often calling them, subcapital or transcervical, which, perfectly correct, but for our purposes, those two hip fractures are treated the same. If they're non-displaced, we usually put screws in them to hold them in place, trying to preserve the hip. If they're displaced, as I said, above 60, we're often doing one of the replacement options, either a total hip or a hip hemiarthroplasty, meaning just replacing the femoral side. Then your intratrochanteric hip fractures, those are the ones you're seeing the gamma nails for, and whether they're, no matter which line they're in, anywhere inside the trochanter, those are fractures that often are fixed because they're extracapsular hip fractures, so those heal quite readily. The subtrochanteric fracture, those are a little higher energy injuries in the younger patients, and in the older patients, these are the ones that are often associated with bisphosphonates. I know there's some evidence in the literature that if patients are on bisphosphonates for an extended period of time, they could be at risk for fractures, and this is one of those pathologic type fractures that we see in elderly. It does not every subtrochanteric fracture is a result of bisphosphonates, but that's one of the ones that we see from time to time. Your greater trochanter fractures, you may have noticed if you consulted us and it was just a greater trochanter fracture, those are the patients that you assume are going to have hip surgery, and then the orthopedist comes and says, no, they could be weight-bearing as tolerated, they don't need surgery. And those are because they're just isolated greater trochanter fractures. So the weight-bearing surface is still preserved, and we usually just prevent them from doing hip abduction to try to prevent some of the displacement of the fractures. Not every single one of these ends up being non-operative, but the predominance of them are non-operative fractures, and we try and treat them that way. Lesser trochanter fractures are pretty rare, but if present, are often managed non-operatively as well. You may notice that some of the post-op trochanteric hip fractures with the gamma nails, sometimes this lesser trochanter looks like it's floating in the breeze, and that's not because we forgot about the lesser trochanter. Those are fractures that do very well without putting the lesser trochanter back, and as you know from the anatomy, those are dangerous areas to be operating to not get any increased function out of it, so that's why we often will leave those alone. And these schematics here just basically repeat what I was saying. As we were talking before, the non-displaced femoral neck fractures are often treated with cannulated screws. The younger fractures, we typically may consider a plate with the screw to get a little more support to try to prevent any displacement. But the elderly non-displaced or valgus impacted femoral neck fractures are often getting screws like this. I alluded to the gamma nail. This is a gamma nail here, which is the treatment for a trochanteric hip fracture. And you can see here is an example of the lesser trochanter kind of floating in the breeze there. And then this is the treatment for a displaced femoral neck fracture. Here this is a hemiarthroplasty, just involving a replacement of the thigh side, but not fixing the pelvis side. And that's a good treatment in our more elderly patients. And then for the subtrochanteric fractures, a lot of us are putting the long nails in because those are often less stable fractures. So joint aspiration, Septic joint is another reason we get a number of consults. And if you don't feel like the patient is septic, if you just feel like their knee is septic or elbow or whatever joint you're concerned about, if you could hold the antibiotics, that would be ideal. So that way when they do get their aspiration, we can get a good idea of what bacteria it is. And then we could give them the antibiotics as soon as they get that aspiration. It just helps to prevent some ambiguity for a number of these patients. Why is that a surgical emergency? We're concerned about the cartilage health, and a lot of times it's the enzymatic breakdown of the cartilage that occurs if they're septic for too long, and that's often a result of the neutrophils. So laboratory diagnosis, once we aspirate these joints, what happens? Often they already have a CEC, a UA, ESR, and CRP that'll help guide us, but it's the aspirate which is the main deal. And we'll try and get a gram stain and we'll culture them. I often order for AFB and fungal in addition to aerobic and anaerobic, although it's very rare that those AFB or fungal are positive. So certainly you can make an argument for only doing that at patients that are higher risk for those first two. Crystal analysis is key. I just had a consult, I think it was last week or maybe even the week before, for a patient that was extremely uncomfortable, didn't have any fevers, didn't have a white count, but had a huge swollen, painful knee. And when I aspirated it, it had some really high number of white cells. I want to say like 90,000 or something like that, which would put her in the infected range. But it turned out she also had positive crystals. So after watching her for a day, she just had gout. And once we had treated her gout, she was much better. Otherwise, if we hadn't ordered the crystals, she would have had an unnecessary debridement in the L1. And as I said, these numbers are not hard and fast. This 50,000 white count, as you heard, I just violated that last week. But you know, it's important, just like any other laboratory value, to look at the whole clinical picture. And there was just nothing about her that appeared to be an infection, despite her high white count. Pseudo-gout is also another one to keep in mind. I've seen that a number of times with patients having high white counts and a lot of pain and fusion. Antibiotics, these days we're often double covering until we can get the exact bacteria and what it's sensitive to, just because of how many resistant bacteria are out in the community. Often we're recommending bracing after an aspiration, for instance, of the knee. We would splint the knee with the knee brace above, certainly splinting an elbow or whatever, just to immobilize the joint. These are some examples of different joints and how we often aspirate them. For bursa, like the elbow, a common thing we're seeing in the office is olecranon bursitis. So for that, obviously you don't want to go into the joint. When you see a big egg on the back of the olecranon here, the dorsal surface, those are not ones that you want to try and get into the joint with. Sometimes those can be infected, so the last thing you want to do is take olecranon bursitis, which is extra-articular, and seed some of that bacteria inside the elbow joint. So just aspirate the bursa itself. And an infected bursa, as I said, is not intra-articular, so that is not a surgical emergency, although some of them may require open or arthroscopic debridements at some point. Laceration over the joint. So how do you know an open fracture is truly open? A lot of times they will bleed significantly for long periods of time for it to be a small laceration. That's one way you could tell. But the true way to tell would be to actually inject some fluid into the joint in question and see if it comes out of the laceration. Some people have described methylene blue. Having done that in the past, it's just a huge mess. It's easier just to use saline. If you're talking about a knee, you want to use a more significant volume because obviously the intra-articular volume of a knee is more significant. Or if you're talking about an ankle or an elbow, 10 to 20 cc's of saline should be fine. And even 5 cc in a wrist should be fine. And those are also good numbers to use when aspirating those joints as well. If you have a septic knee, you're definitely going to get out way more than 20 cc's of fluid. So if you use a 20 cc syringe, that should be plenty of sample to send to the lab, even if some of it gets misplaced. Compartment syndrome, that's a common thing that we get consulted for. What is compartment syndrome? So essentially, the swelling in that specific limb is more than the blood supply going to it. Unfortunately, these numbers are not hard either, but a lot of times greater than 30 millimeters of mercury in that compartment, or a delta of 30 millimeters of mercury from the diastolic blood pressure are good guides to use to try and figure out if they do have compartment syndrome, and how do we figure out what the intra-compartmental pressure is. There's a striker needle. It's basically a device that you stick into the particular compartment, and then it tells you the pressure immediately. I think the OR, they have one, and I know I've used the one in the ED a number of times. What are some of the signs? Obviously, not a whole lot of people feel comfortable sticking somebody with compartment syndrome in the compartments, but what are the things that would make you call me or one of the other orthopedists? Pain with stretch out of proportion to exam, pallor, so obviously pale skin, paresthesias, poikilothymia, which is varied temperature within that specific limb, paralysis and pulselessness are rarely seen. Those are usually at the end of compartment syndrome. And a lot of times by that point, it's too late to open up the compartments. You can actually end up with infection from opening up compartments after the compartment syndrome has passed. Surgery pre-op, there's really nothing to this. We obviously want to know if you're calling us for something that you think is going to need to go to the OR. It does help to know when the last time they ate was, because that's the first question the OR asks us. So if we're trying to plan when we're going to do the surgery, that's helpful. If it's a hip fracture or lower extremity fracture, especially in elderly, it's good to know what their pre-injury ambulatory status is, so we can tell the family what to expect. Approximately 50% of hip fractures get back to the way they walked before they fractured their hip. And most family members want to know, well, what happens to the other 50%? Well, 50% of those, or 25% of the total, take one step down. So if they were walking unaided, they may need a cane in the future. And some families are under the impression that if they get a total hip, they'll go from a wheelchair to walking normally again. As I'm sure most of you know, that's not true. So it just helps us to set the stage for what the family should expect. The other helpful thing, especially if they're having surgery, is when they last took their anticoagulants or which one they're on, and that also helps us to plan with the OR when we can get them in. And the lab work is pretty self-explanatory. So what are the things that I do on a regular basis? Well, tomorrow I'm doing a total knee. And total knees for the last couple months here have been done with the robot. And a number of my patients, when they hear about the robot, they say, well, are you going to be there? And obviously, not only are we going to be there, but we're still doing the surgery. The thing that the robot helps us do is, at least the way I did it prior to a few months ago, was that we would put a rod down the femur bone here and a rod down the tibia bone here to make sure that we were making perfect cuts on the end of the bone. And with the robot, they get a preoperative CT scan, which you can see results of here, which allows us to make sure that we're making straight cuts. And it allows us to make sure that we're doing that in multiple planes. And what this is showing you is we can actually decide on our cuts before we make them, and then see how it looks on the patient's bone. So before, we made the same cuts for everybody. And then depending on how loose or tight your knee was, if it was tight, we may take a little more bone. If it was loose, we may put a little more polyethylene, which is the thing you can't see in the space here. But with the robot, we're able to make extremely precise cuts for each person, so we could figure out, exactly how much bone we want to take off, which is is this gray area, that's the bone that we were taking off. And then this green is actually the components superimposed on the cuts we've not yet made. So that makes it a lot easier to be able to do really patient-specific cuts, opposed to some of the things that have been advertised over the past few years, which are patient-specific jigs. That means cutting guides for different patients. The cutting guide, once you made a decision, that's it. Where this, we could dynamically, while we're doing the case, change the cuts to see what, to fit the patient that we're looking at. And then down here, this is just an example of what it looks like while we're actually making the cuts. So there's a pretend saw here, and you can see the green, and just like a video game, when you're pushing this saw, which you can see up here on the robot in, this part, this green goes away. So your goal is with the saw is to get rid of all the green. And there's also a color of red if you skive a little bit. But I think that's just like 0.5 millimeter. So even skiving is really not a big deal. What does it look like intra-op? So you can see here, this is a right knee. This is the robot draped behind, the same robot you're seeing here, holding the saw itself, making the cuts. These are arrays, and that helps the robot to know exactly where the limb is in relation to the robot, so we can make sure, even though the limb may be moving around, that our cuts are in exactly the same spot. And then this is just an example of post-operatively what it looks like. This is a cemented total knee. A lot of the younger patients now, we're doing uncemented, which means that the bone actually grows into the back of the implant. And the theory there is that these would last even longer than the cemented implants that we're doing in both elderly patients and that we were doing before this technology was available. So rotator cuff repair, that's another common surgery that I do. So those are done arthroscopically now. There are some people across the country who are still doing them open. I think those are fewer and far in between. My personal preference is to do them with the scope, and in my opinion, there's really no rotator cuff that I could fix open that I couldn't fix with the scope. And that's for obvious reasons, at least in my opinion, which is the magnification that you get from the scope and the less soft tissue dissection you have to do. We can do any rotator cuff repair that's possible with just a few little poke holes, which you can see here. Often they'll have a minimum of 3 poke holes. Most of my patients have between 4 and 6. Then how do we get in and out of the skin? You can see these commercially available cannulas make it easy to get in and out of the skin. And then this would be before the tear is fixed. This is the humerus down at the bottom of the page. That's the greater tuberosity after we've cleaned off some of the bone to get it down to a bleeding bed of bone. And then this is the rotator cuff that you're looking at here that's torn. This was a supraspinatus tendon. And then you can see down here, we put an implant right underneath here, one underneath here, and those implants essentially look like screws with some thread attached on the end. And then you can see where we put that thread through the rotator cuff here, and then the different strands we cross over. This is called the double row technique, and that helps not only to pull the rotator cuff down, but then to create some compression. Plus, for my less compliant patients, it makes them tear off 2 separate rows of anchors before the rotator cuff repair would fail. ACL reconstructions, I mentioned that I'm on the sidelines of a number of different teams. So these are common injuries that we see on the sidelines. Not as commonly do we see that knee dislocation of the kid I was talking about previously, but that kid required ACL reconstruction as well as a number of other ligaments that we reconstructed. What does an ACL tear look like intraoperatively? Again, this is done completely with the scope. If you've seen incisions on patients, it was likely to get the graft out, not to do the actual procedure itself. So if you look here, this is the ACL, and you can see where it was torn completely across here. And this is another view of it from the other side. If you're looking at the front of the knee here, so the femurs in the back, tibias down below. Often I'll make a minimum of 2 poke holes, one on either side of the tendon, and for a lot of the patients, depending on their anatomy, we'll make a third here to be able to get a little bit better angle. If they're a younger patient, we often use their own graft tissue, and my preference is, especially in these bigger football players, to use a part of the patella tendon. So the patella tendon width is usually between 30 and 38 millimeters. So we usually use the middle 10 millimeters, and we take a little sliver of the patella and a little sliver of the tibial tubercle, and that's what this is showing here. So bone on both ends, and screws holding it in place on either side. And intraoperatively, this is what it looks like when we're done. It can also be, one of my partners is a big proponent of using the hamstring tendons. Those can be done with a much smaller incision. The negative aspect of those is obviously the hamstring tendons have no bone on it, so you're requiring tendon to heal the bone, opposed to bone healing. And if you're into sports at all, I challenge you to name a name of a sports player who had hamstrings opposed to the patella tendon, because most of the mainline sports players all get patella tendons, and that's again because of the bone to bone healing. That's my crew at home. That's the office number up at the top. So if you do have consults or questions or anything, that's our office number. This number below, it's not a misprint. It's not 504. It is my cell phone. I'm from Boston originally. So even though my wife likes to remind me I haven't lived there since 2001, I still have a Boston cell phone. So if you have any questions, call me, text me anytime. That's my cell phone. Any questions, concerns?
Like after a rotator cuff, what's your protocol for rehab? Immediate, or wait a while?
Sure. So if it's a smaller tear, I'm more aggressive with those patients for 2 reasons. Number one, they're less likely to fail. And number 2, the smaller tears are more likely to get stiff. So it's different depending on how big or small the tear is. For a small tear, the more aggressive rehab, wears a sling all the time for 3 weeks. And then during that time, they're doing range of motion exercises. They're doing passive range of motion. So let's say it was my right shoulder that had a rotator cuff repair. I would take my left arm and I would bring my right arm up like that. So passive range of motion is 90 degrees. And we would do that in both forward flexion and abduction just to try and prevent scar tissue from forming. And then we would have them do pendulum exercises below for those first 3 weeks. And then after that, I would send to rehab. Where my larger tears, or if it's a revision of a previous tear, those are in a sling all the time for 6 weeks. And then the same rehab would start from there. But no active range of motion, which means using that tendon that we repaired for 6 to 8 weeks, again, depending on the quality of the tissue and the age of the patient and how big a repair it was. Any other questions? Thank you.
Yeah.